Good evening, and welcome to the Psi Phi Fraternity Incorporated 2nd District Health and Wellness Committee. We have monthly webinars where we talk about preventative health in communities of color. I am a retired pediatrician and internist who will be your moderator for the evening. Tonight we have a special treat for you guys. As this being Mental Health Awareness Month, we're going to have a conversation about mental health in a different way. But before we get started, I'd like to introduce my brothers, and I'll start out first with the chairman of our committee, Dr. Jedan Phillips. Take it away, Dr. Phillips.
Good evening. How you doing this evening, 78? Great seeing you. My name is Jedan Phillips. I am a board-certified family practitioner. As a primary care physician, one of the aspects of my care that are becoming more and more significant is addressing mental health issues. So when we talk about mental health and mental health awareness, unfortunately, our community suffers as far as its ability to address this growing problem. So again, I'm excited about this conversation this evening because we're going to talk about what is going on and what are some things that we can do to help ourselves and help each other. But the other thing that I think is important is addressing the stigma that occurs. I know growing up for me, it wasn't really embraced to talk about I'm feeling anxious or I'm feeling depressed. So you didn't really always feel you had a space that you would be supported in to talk about how you felt. So I think as we are now seeing that many of our vulnerable communities, in addition to their vulnerability being related to medical issues, diabetes, heart disease, etc. Another factor that rides in those same areas is mental health issues. So again, excited about tonight's discussion, excited about our guests that we have, and looking forward to this discussion this evening. Thank you.
Thank you, Dr. Phillips. Before we go further, let me just say that the views and ideas presented here tonight are not necessarily those of the Psi Phi Fraternity Incorporated, but rather of the individual brothers and presenters themselves. So with that note, we'll go ahead and have Dr. Wingfield, Dr. Ed Wingfield, 92, come on, give his introduction.
Hi, good evening, everyone, and welcome. It is, as always, an honor and privilege to be on this panel. Looking forward to engaging and learning a lot myself. I'm an interventional cardiologist. And the cardiology space deals with medicine, deals with mental health. It is something that on a daily basis that we see. So as I said, looking forward to engaging and being a resource to assist in the conversation and learn as well from my standpoint. So thanks for having me. Thanks for being here.
Thank you, Dr. Winfield. Now let's hear for our illustrious Dr. Isabell. Come on, 95. Tell us about yourself.
Good evening. Thank you for being here. Dr. Lee Isabell again, board certified internal medicine. I do primary care, outpatient as well as inpatient care. I see mental health every single day in my practice. And it's very undertreated, underrepresented, and I'm glad to be here. Thank you.
Thank you, Dr. Isabell. Now we'll hear from Dr. Plummer.
Hi, good evening. My name is Dr. Plummer. I'm board certified OBGYN and board certified in maternal fetal medicine. I specialize in high-risk pregnancies. Mental health is also an important aspect in the community, and also with dealing with women and also pregnant women, because a lot of women suffer in silence with mental health disease. So it will be a great, robust discussion that we will have with our brothers to talk about mental health and how it affects the minority community.
Thank you, Dr. Plummer. And last but not least, we'll hear from our good brother, Dr. Kelvin Ford.
Good evening. My name is Dr. Kelvin Ford. I'm a board-certified internist practicing in Prince George's County, Maryland. As you've already heard from my brothers, mental health is something that we definitely need to address. It wasn't talked about a lot early on, but now hopefully we can make everyone more aware and that so they can get help. Thank you. Looking forward to the conversation.
Thank you, Dr. Ford. And now it's my privilege to introduce our guest for tonight. His name is Dr. Tiresias McCall, Brother Tiresias McCall. I'm sorry about that. He is served in the United States Marine Corps for many years. He served as a juvenile probation officer, a juvenile correctional officer, special education teacher, middle high school administrator, and has been over 27 years in the mental health space as a mental health specialist in the community schools and judicial system and life. He is a 2001 graduate of Tuskegee University with a degree in psychology, a 2010 graduate of Howard University with a master's of special education, and a 2016 graduate of University of DC with Master of Mental Health and Vocational Rehabilitation. He serves as a child advocate and life coach. Brother McCall said he's a servant to all. And he has become a mental health and is a bridge to all. So without further ado, Brother McCall, take it away.
Gentlemen, welcome. Can you hear me?
Yes, we can hear you.
Can you hear me?
Yes, we can hear you.
Yeah, absolutely.
I'm honored to be here amongst the brethren on this call today. Mental health is something that's dear to me. I've been around it for my entire life. I'm a Southern boy from Alabama, and a lot of things we've told, and we had cousins and family members that was dealing with various things. And in the good old Southern South, we just say, pray about it, talk to God about it. And that was the answer for everything. Talk to God about it, talk to God about it. And a lot of issues and concerns that we suffered from was overlooked, and a lot of things came from that. So hopefully today on this panel, we'll be able to address multiple things. But at the end of this panel, each one on this call and everybody who listens to the sound of our voice will walk away with some opportunities and ways to love yourself. Mental health is addressing the things that you need to address and loving on you so that you can be strong and be there for everybody else. Thank you very much. I'm delighted to be here.
Thank you, Brother McCall. So as you know, we just coming down off a big pandemic, the COVID-19 pandemic. And one of the biggest issues, one of the biggest fallouts from the COVID-19 has been mental health, particularly in our pediatric space. So, as a practicing pediatrician for many years, I had to deal with many issues with anxiety and acting out and other things because the way children felt they were not a part of society. So mental health, we're going to talk about tonight, not only involves the adult population, but a significant amount of the pediatric population, particularly the very young children, because they look to us as their guides and they look to us for how we react to situations. So we have to be very careful how we address situations that deal with mental health. But I want to preface this by saying one thing that I want to get straight right away. Mental health is not crazy. It has nothing to do with being crazy. Mental health is just another part of our general health. So I want you to think about somebody that said he's crazy. Just get that out of your mind. That's a colloquial term for, jive stuff. We talk about that because mental health is a serious part of our medical checkup and our medical well-being. So, Dr. Phillips, you mentioned in the beginning, you have a lot of things you deal with because you deal with both as well as I did with children and adults. So what are some of the things that you're seeing in mental health that?
Well, I think, again, when we look at this pandemic,
to communities of color,
when we look at this pandemic, and what did it do? Number one, it isolated people. And I mean, I think, I've been very fortunate where I'm staying, if I had a problem with my wife or son, we could all retire to our corners and have space. But what about those individuals where you didn't have the ability to be alone or to have some personal space? Or better yet, if you lived alone and you had nobody else to engage. So I think that isolation contributed to probably already present mental health issues. Again, if you look at communities of color, we are those that have the poorest access to mental health services. So even if we do have a problem, most cases, we don't have some place where we can go to get that problem addressed and come up with some solutions. Again, the other thing you saw was how life in a very in its routine way was disrupted. We lost family members and friends And I'm not saying that death doesn't happen, but when have we had death and you cannot appropriately and respectfully close that chapter of that individual's life? So I think there was some differences that occurred in the unique aspect of this pandemic that highlighted an already present problem. You know, say I see 25 to 30 patients a day, you know, I would say 3/4 of them, there's a mental health issue involved. And I'm sure all of us in our particular practices see people that, again, they may have something that doesn't involve you, but because you might be the person they like to talk to or feel comfortable, you know, and we do inquire about how you feeling today, you know, they let you know there's a lot going on. So it is becoming a more and more substantive part of my practice. But I think the other thing that makes it good is we have a mental health practice and arm of our practice that's embedded within. So we have psychiatry, social work, and psychology that are involved so we can refer within the practice, making access a little easier. Lastly, again, using telehealth as an opportunity, and that's been helpful in getting people seen sooner than they would have.
You know, you touched on something that kind of very interesting, and that's why I asked Brother McCall to come on tonight. He had when I first met this brother on a podcast, I don't know how long ago it was, but we did a podcast. He had a very, very interesting approach to mental health. And we also served together on a United Christian Fellowship workshop where he did a workshop for us. So, Brother McCall, if you don't mind, will you just tell your story about love that you first talked about on the podcast? I was really impressed about how you brought that to light, how people need to look at themselves first. Can you tell us a little bit about that?
So, gentlemen, thank you, Doc. Anytime I deal with anybody, I start off by saying, I love you, I believe in you, and I trust you. So the words I love you are words that we associate with love, romance, kissing, touching, and there are various aspects of love. If I ask the gentleman on here or everybody listening today, they will all have a different definition for love. But because of how we see love or how it has been given to us, we struggle to give it back. I believe in you. Everyone tells you about the things you can't do. If you tell your best friend, they say, if you want to kill your dream, tell it to somebody you love. If you want to kill your dream, tell it to somebody you love, because they're going to tell you, well, you come from your poor area, you don't have this, you don't have money, you don't have this. So I start off by telling you, I love you, I believe in you, and then I trust you. Only you could study, only you could sit down and buckle down and apply the things that you're studying to make it applicable. Everybody in front of me are all doctors right now, OBGYNs, retired pediatricians, and family medicine doctors, and each of you applied a skill set where somewhere someone exemplified and expressed and showed love to you. You believed it, showed that they believe in you, and they trusted you. Well, that I love you, believe you, and trust me came from my second grade teacher. I grew up in, I was born in Montgomery, Alabama, but at 4 we moved to Andrews, South Carolina. And I had an older lady. Looking back, now I was in the second grade. I'm sure she was in her late 60s or 70s, but Miss Hughes. And I had a real stuttering problem, a speech impediment. And kids would make fun of me, and I could not say my name. I couldn't talk, and it was just a horrible situation. But each and every day, Miss Hughes would call me to the front of the classroom and say, baby, I love you, I believe in you, and I trust in you. And those words manifested in my spirit to now I tell everyone I meet, I love you, I believe you, and I trust in you. And if she would have walked away from me, or she would have called me cuckoo, if she would have called me crazy back then, there's no telling how I would have grew up and what I would not have manifested into. But because she exemplified and showed me love and showed me what it looked like and how it felt like, I made a promise with the good man above that I would spend the rest of my life doing what I've done over my career. So that's what Dr. Boykin is referring to. But as we go through this panel, throughout this conversation, we're going to show each individual how to love and believe and trust in yourself. As I stated, I don't know where you come from, but each one in front of me on this panel right now, at some point in time, someone doubted you, told you what you couldn't do. You defied the odds. You loved yourself. You believed in yourself, and you trusted yourself. And look at you now.
Wow, profound conversation. So, Brother McCall talks about love, and I think that hits back to what Dr. Phillips was talking about, isolation. When you isolate, that was one of the biggest problems we saw with the pandemic in children. Adolescents already trying to discover themselves. They're trying to find out who they are. And so we had an increase in the number of adolescents showing up at the emergency rooms during the pandemic. So I know a lot of the brothers on here have had similar situations like that. What are you seeing now in your practices post-epidemic that you're dealing with every day, whether that you cannot get away from? What are some of the things that you're seeing, particularly from a cardiologist point of view, Dr. Wingfield? You said, you see that even in your practice in the world of cardiology.
Yeah, I think one thing that is important.
Can't hear you.
Okay. I think one thing that is important for all of us is the relationship that we all have with our patients. We deal with our people, and we connect with our people. And even as a cardiologist, I hear the stories of what's going on at home and the issues with mental health, not only from my patients directly, but perhaps from the family situation, the mom who's having issues with dementia, and the son who's having issues, and the mom who's at home who's trying to hold it all together, as well as manage her health. So in a lot of cases, this mental health can be a detractor from taking care of your overall health. So having that relationship that we have, where we can just kind of talk to our patients really confide in us. That's one aspect of the mental health journey that we all are part of, and I embrace it. I really spend additional and extra time with patients that look like me to try and help out and try and be a voice of reason or a voice of support beyond just the heart care. We deal with issues like anxiety. And I tell patients all the time that anxiety is the great masquerader. You can have situational anxiety, where you get these attacks of palpitations and stress and feelings of impending doom and really not know where it's coming from, right? Palpitations and those things that we can treat being irregular heartbeats and the feeling of tightness in the chest. A lot of symptoms that can be mistaken for a heart attack or a heart ailment, and anxiety can manifest in those ways. So certainly, if you are having those issues, that is something that you should see your primary care provider, and we can address it if there is actual etiology that is heart related or mental health. Is an aspect that can be addressed. So I think all areas of medicine, we deal with the mental health game, and it's something that as practitioners, we can be a voice of support, a voice of reason, and direct these patients to the proper channels to let them know that this is no fault of yours, and this is something that we can all act on and help with.
Yeah, you make an interesting point there. I think a lot of people are afraid to go and seek help because.
Yeah, I would agree. Again,
think that guys gonna think they're quote unquote crazy for having symptoms. Maybe
I was just going to add on.
Go ahead, Dr. Phillips.
Again, a lot of people they don't want to seek it because of the stigma involved. Again, that's a big problem. I mean, I know in my house, I didn't feel comfortable when I was a youth going and saying, hey, I'm anxious or I'm depressed, or even if I was, what do I do after that point? But go ahead, team. I just was taking over for technical stuff. So
that's okay. It seemed like we have some technical difficulties tonight a little bit, but what I was saying was that, we have people that won't come forward, and we might miss something such as they might miss their own symptoms of having a heart attack because they think, well, somebody's going to think I'm crazy because I'm having all these symptoms. And it might not be related to your heart, as Dr. Wingfield said. It's just your own anxiety is manifesting those symptoms. So, Brother McCall, how do we get people to get past that part of I don't want to go because people will think I'm crazy. Any suggestions for us in that?
So first thing first, Dr. Wingfield mentioned anxiety, and in my world, when I talk to my people that I talk to, I address anxiety as unfinished thoughts and actions. Anxiety is the result of unfinished thoughts and reactions. So if I am truthful with myself, we are all overbooked mentally. There are many things that we want to get done, but we don't narrow it down and have short-term goals and long-term goals. So we have things that we want to accomplish, we have things that we haven't accomplished, and things that we desire to accomplish. But on top of that, you have to be a husband, a father, sister, brother, a person. You have to go to job. You work 2 or 3 jobs. So if you're trying to accomplish something in your personal life, but your real life is drowning you out, it leads to anxiety, unfinished thoughts and actions. So first thing first, we got to clean our plate, Dr. Boykin. There are a lot of things on our plate that's on the plate. We want to make everybody happy. We got a honey to-do list. We got a child to-do list. We got a work to-do list. We got all these things that we're doing for everybody else, but we don't do it for ourselves. So the first thing we need to do, Dr. Boykin, and everybody on the panel, anybody listening, we have to cut the fat off the hog. A lot of times when you clean your chicken, we from the barbecue, or we do whatever we do, we have to trim the fat off of the hog to get to the meat. The meat is that thing that we want to accomplish, but the fat keeps us from getting there. So to control our anxiety, first thing first, the first set of loving yourself or believing in yourself and trusting yourself is trim the fat off the hog. Address the things that's a necessity and put the wants and desires to the side.
Thank you, Brother McCall. Now, Dr. Plummer, you live in a kind of a different world where you see things that are a direct product of having a child. Things you do. You and I both have to look forward to after during the pregnancy and after pregnancy, and that's postpartum depression. Can you give us a little spiel about it? Because I'm sure there's some people out there want to know about postpartum depression. Do I have it? What do I do with it? And or the caregivers, or the husband and wife, or whoever might want to say, how do I recognize it? What do I deal with it? Any thoughts on that?
Well, postpartum depression can also be another gateway from having depression already before the pregnancy. So women that do happen to have depression before the pregnancy are at increased risk of having postpartum depression. Now, postpartum depression is significantly feeling down, crying for no reason. There's a certain questionnaire that they usually will fill out after they deliver. Are they crying mostly? Do they want to harm themselves? Do they feel sad about having the baby? These type of things that are underlying. And those things need to be recognized because there's a lot of things that can be treated by, therapy. A lot of things are usually a lot more treated now with medication. Also, there's an IV medication that they have to give for over about 60 hours. Xarelto, it's one of those postpartum depression medications. But one of the things is you want to recognize it. But as I said again, a lot of women are the caregivers of their family. They're usually sometimes single mothers. They are having a lot of responsibility on them with the pregnancy and also taking care of other children. They might be caregivers of an elderly person, and what they try to do is hold everything all together. And by holding everything all together, as Brother McCall might say, you're suppressing all that and you're keeping all that in and building, and it's just worsening and tearing you up inside. So one of the things we are trying to do is to have availability for therapists or someone to talk to. And I think also with COVID, we learned that Zoom, or we learned that telemedicine is a way that they can have immediate contact with a psychiatrist or a mental health provider compared to going to the emergency room in a psychotic event. So that's basically
Dr. Plummer, question for you.
Yeah.
What I have seen, and I, as a primary care doctor, do get to take care of women in the postpartum phase. a lot of times this type of depression responds better with medication than other types of depression. Is that your experience as well?
Well, I mean, in my experience, I don't deal a lot with deliveries and postpartum because what I usually do is just specialize with the pregnancy itself. But I've seen a lot of medications. So SSRIs are also very good. Now, the thing with SSRIs is that usually it takes about 2 weeks for it to become therapeutic. So therefore, women that are showing signs of depression or have a history of depression before and they're doing well on SSRIs, we recommend that they either continue it or also take it in the later part of pregnancy so it could be at a therapeutic level. So after they deliver, it will help manage their postpartum depression. And SSRIs, they're safe in pregnancy. They're also compatible with breastfeeding. So it's a medication that is easily used for that cause. But sometimes group therapy, sometimes a family member support system, that is really important because they have a new baby and they don't come with instructions, so a lot of them are, dealing with that. And then their mother is far away. They had to move to another area for a job location or that, and they don't have that family system anymore, that structure, which, if you really look at it, even in our culture and even in African culture, every delivery was around, family members or around a group of women that knew you and loved you. And also that also nurtures and helps you, guide you with the new child. Now, you take away that system, as you can see with COVID, or it could see in it just moving away. When you don't have that support system, it can spiral. The depression can start and spiral down to where you could get into postpartum psychosis, where you could see actual person hurting themselves, killing themselves, or hurting the baby. When it gets to be that severe.
So this question is for anybody. What are the biggest aspects of mental health are we seeing in our communities of color that are not being addressed because people don't feel like they should come forward? What are you guys seeing or hearing as providers to people? The biggest things in the communities of color that is directly related to mental health. Anybody want to take that question? I know you see a lot of specialized care, Dr. Isabell, with your HIV practice, and Dr. Ford, you have a pretty significant amount of people you see on a daily basis. So anybody, just tell me some of the things we need to address in our communities that are related to mental health that people might not come forward with.
Well, depression in general, we see a lot of depression. I mean, from all the reasons we talked about, from the isolation, just the things that are going on in their life. But what we have to do, patients aren't going to necessarily come in all the time and say, hey, I'm depressed.
Right.
We have to actually screen them and be aware. Oh, I can't sleep. I'm waking up in the middle of the night. I'm just so tired. So we have to be attuned to that. Wait a minute. Let me screen that patient for depression. And there are different tools that we have doing these 2-question depression screen or the 9-question depression screen. So we have to be aware that there's possibility of depression and also even anxiety. Because just like Dr. Wingfield said, they're not necessarily coming in and saying, hey, I have anxiety and that's why I'm having my palpitations, right? So we have to really be attuned to that.
I think another thing to add on to what Dr. Ford was saying is a sensitivity to these moments where one may have depressive issues. I think as we get older, life changes, change of career, retirement, significant surgeries, joint replacements. Those can be moments where a person might be vulnerable to, the possibility of some mental health issues. So as a provider, being a little more aware in your questioning of patients during those times to be noticing if they're having a problem.
So I guess, Brother McCall, what are the, you've been at this for a long time in the mental health space. What are some of the trends you've seen over your years that have directly affect the African-American community?
Dr. Boykin and panel, we don't come forward. We have been told that we're strong and we're not supposed to be emotional and we're not supposed to talk about this. It goes back to that old Southern belief. Just talk to Jesus about it. Talk to God. We take everything to God. We take it to God and leave it there. And we literally take it to God. Hey, God, I'm struggling. I feel like killing myself. What you gonna do about it? And it goes back to the spirituality. Faith without work is dead. So I can tell him what I need, but if I don't follow through with it and go talk to my primary doctor, I don't go to a mental health specialist. And the other thing is the lack of mental health specialists being available, or if I go to a mental health specialist and if I don't find that person the first time, it's like a pair of shoes. If you try a certain brand of shoes and you may like the way it fit or maybe the way it looks, but if it don't fit your feet, you put it back. The same thing with the mental health specialist. A lot of us try the first time and we don't lock in, or we don't like the person, what they said to us, or maybe the mental health specialist is too real. Like, nah, he's stepping on my toes. I ain't trying to hear that right now. So the same way the mental health specialist may not be available, we don't take the time to truly seek the help that we need because we're not ready to face the truth. We're not ready to make the changes that we should make. So therefore, we don't do it. We just quit. We just move along. So the main thing is that we refuse to address that which needs to be addressed, which is our inner self.
Thank you. You have something, Dr. Phillips, you wanted to add?
Well, just to go with that, so as providers, knowing that people are not so intentional in bringing that up, how do we catch it? Physical exam is a point where you can have some routine evaluation and questioning that can highlight if there's a problem that needs to be delved into. In offices, like Dr. Ford mentioned, we do mental health surveys. And again, with a lot of the insurance companies now, they're more goal-oriented in their reimbursement. So these types of screenings are going to, as a doctor or medical practice, may get you more or higher level of reimbursement or payment. So it actually benefits you not only to serve the patient, but it could also be more profitable to you in your practice if you are evaluating or screening people for this.
Thank you. Dr. Isabell, we haven't heard from you tonight. What do you want to add to that?
What I want to add to that regarding mental health, like I said before, I see it every day. All what we have to go in more detail, we have the PHQ2, which asks the question, are you loss of interest in doing things? Are you feeling depressed? And sometimes after those questions, then you go to the PHQ9, which is a little bit more detailed, and you would ask questions, loss of appetite, people notice you're moving slowly, for example, and thoughts about hurting yourself, loss of concentration, insomnia, not sleeping. Sometimes, honestly, I find out in the office, the nurse answers those questions and they say everything's okay, but then you answer, they're comfortable with you, and they may open up, and then those questions were really yes. I find out there is a shortage of primary care. Well, there's a shortage of psychiatrists, or could be a waiting list. Yes, telehealth has helped a lot. Some people still like that in person, or you may have a therapist a psychiatrist that may, just put you on medication and not really talk to them to get to know them or look at them in the face. That's what some patients say. I have some patients that come to me. I say, I'm a primary care. I'm not a psychiatrist. They said, but they feel comfortable talking to me. You feel like my psychiatrist. And I see that a lot. Mm-hmm. And it would help with their medical problems too.
Go ahead.
Because a lot of times, if they have hypertension, diabetes, if someone's feeling depressed, they may not take their medication. They may not follow their regimen. So if you can, or for example, we have a lot of chronic pain. It can make someone's chronic pain worse if they're depressed. And then there's, of course, anxiety of going for preventive measure tests, like, for example, colon screening, screening for, heart disease, or they may not even go for those tests because they have severe anxiety that something's going to be wrong, and they have cancer, and they're afraid of that. So those are some of the things, a lot of things I see in the office.
We have a lot of general mistrust with the medical community in general. And so how do we get past the mistrust of doctors? Because a lot of people in our community, communities of color, don't want to go to the doctor because they don't feel like they're going to be heard. They're not going to be treated as so-and-so. They're going to treat me as a number and not as a patient. Just, I'm trying to make reference to what you said there, Dr. Isabell. So how do we get past that? This is for anybody on the panel. This is open discussion. How do we help people to get past that part of, like, we really want you to be able to come to us and talk to us that you're having a problem that's not related to I cut my arm or my chest hurt. How do we get past that problem?
Well, Dr. B.
Go ahead.
Isabell. Dr. Isabell, go ahead, sir.
You got to get you have to get the trust of the patient. If the patient trusts you, then those things can fall in place. If they don't feel comfortable with you, if they don't feel like you're not listening to them, then you'll have a problem, and they won't share their thoughts, or they won't share that they may be depressed or severe anxiety. So that's the most important thing. If they feel comfortable with you, they will more than likely take your advice.
And that's also important, that they see a person of their color,
Yes.
talking to them. That can automatically, they can also open up. But unfortunately, the situation of medicine and the way it is more or less run now, that you have to see patients within a certain time frame, and usually most of the stuff is data collection between the nurse and or the medical assistant, getting the blood pressure. Then by the time you finally come in and you reviewing their chart, the time factor becomes a little bit less, and then sometimes you might run over on your time, and hopefully the next patient's time is going to be a little bit shorter that doesn't have these issues. So also the system that we also work in, the medical system, also is also a kind of a deterrent too, at least that I've seen.
Another strategy. Go ahead. I'm sorry. Go ahead, brother McCall.
No, just quickly. We put a lot on the doctors already. As Dr. Plummer just stated, you see 25, 30, 50 patients a day. And some of you actually do up to close 50 patients. Y'all, it's a system. But the client who needs the care has to put the iotas on me to seek to seek the help that I need. We have to rebrand this thing called mental health. We have made it everybody else's issue. When we talk about mental health, it's always somebody else shot somebody else killed somebody, but we refuse to talk about our issues, our need, and we refuse to address that which we need to address, purify within ourselves. So it's easier to point the finger at everybody else, but I refuse to accept that there are three fingers pointing back at me, myself, and I. So if I address me, myself, and I don't have the time to worry about everybody else. So instead of pointing the finger at the doctors and whoever else, I have to look at the man in the mirror and address my issues. Go ahead, Dr. Phillips.
No, I was just going to echo what you just said, which is a lot of times what I try to do is just connect it to real life. And again, I had a young man in the office. I mentioned we unfortunately have seen, mental health take a toll on some of our brothers. There was a chap out in Texas, lost two brothers on the same line to suicide. Again, as the primary care doctor, sometimes I got a front row seat to their life sort of falling apart. And when you can compassionately and with respect sort of tie in the mental health to what they're going through, I find that patients, oh, wow, I never thought about this could be anxiety or this could be depression. Because again, you know, we get these stereotypical images of what it looks like, and we don't think about, well, me not sleeping means I could be anxious, or, you know, me just, you know, breaking down in tears, that could have an implication, or me just not wanting to do anything. Oh, I'm just thinking I'm tired. So again, all of these different things, if we don't sort of make them aware of how real these symptoms are as far as it being suggestive of a mental health problem, again, people think they just have, you know, I'm just tired, I haven't slept that much.
Wow.
Can I just add something to that as well, in terms of from us as practitioners, is recognizing when things change in our patients, to be able to kind of tease out that there's something more to the picture, that there's more going on. We have patients whose blood sugars are controlled, and then all of a sudden the hemoglobin A1C is, you know, goes to 12, or the blood pressure, which was once controlled, now is extremely high, because, well, one, they're not taking their medications. But why aren't they taking their medications? Well, mom is in the hospital. We're trying to, you know, put her on hospice. My grandson is, and when we see the structure of the home right now, we see that you have multiple generations in the house at one time. You're taking care of a 2 and a 4-year-old while you have mom who's really sick and going through dementia, and you have a daughter who's out doing whatever, and you are the sole homemaker who is trying to hold all this together, when you just had a heart attack 6 months ago, and you really need to be worried about your own medications, but now you're not taking your medications. So you have multiple generations in the home, everybody going through their different stages in life, and you are the one who's supposed to hold this whole thing together, and you're completely overwhelmed. So as practitioners, when we start to see that, that's why having Brother McCall here, I personally don't really have the mental health resources to say, look, I want you to see this person, right? And every day we start to hear patients talk more and more about mental health. Who should I see? Who can I talk to? The stigma really has to be lifted, but we really need to have those resources where we can spend that time. Because I tell my patients with diabetes, I'm like, look, you have a primary care doc, but you should also see an endocrinologist. An endocrinologist is a specialist who deals with blood sugars and diabetes, and she or he will take 30 minutes to talk specifically about your diabetes, not everything else. So the same with the mental health professional. When we start to tease out that there may be issues that are impacting their overall health, and there are resources out there that we need to be made aware of.
Yeah, you bring a different situation. I want to just piggyback on really quick, Dr. Phillips, that, you know, you see a change in the patient or something mean. Well, in my practice of pediatrics, I begin to see a change in that young man or that young lady's affect. We call it the affect. You know, it used to come in, mom and dad were, you know, were hunky dory, and next thing you know, the kids become withdrawn and silent. And you don't know what's going on in the home, so you have to be able to tease it out. And one of the biggest problems I had in pediatrics was the child really, really wanted to speak to someone other than their parent about the issues that were going on. So we had to be receptive to that, and we have to be able to recognize that and promote to that child that you can talk to me. And the parents need to understand it's not we're trying to, you know, overtake their authority of their child, but we want that child to be able to come to us, have somebody that they feel comfortable talking to. That's the biggest part of pediatrics that I think got left out. You know, having the ability for the child or the teenager to speak to you, tell you as a pediatrician what's going on. Now, there's certain things you have to report to certain authorities, you know, if it comes out. But the main thing is that parents out there, if you hear me, allow your child to talk to their pediatrician or their family practitioner. Allow them to have one-on-one time with them, because you don't know. Brother McCall said cleaning their plate. That might be the first aspect of that person, that child, getting ready to clean their plate. So I'm sorry, Dr. Phillips. Go ahead. You had something you wanted to say.
No, I think you touch on a point that I was going to make, just adding on to what you and Dr. Wingfield was saying, was these points of vulnerability where somebody might have been already identified. I'm getting out of jail. I'm getting out of a mental health facility. I'm getting out the hospital. I'm in school, and they're telling me I need to follow up with a mental health provider. In all of these circumstances, especially in our communities, these individuals can't find that individual that they need to see. And now that 7-day supply of medication that was keeping you even is now running out. And now we got to deal with the ramifications of that. I'm sure if you walked around and saw a majority of the homeless people in New York right now, many of them have fallen through the cracks because in their transition from different places, whether they were incarcerated, hospitalized, etc., they have not been able to find mental health services to take over for what they had received, or maybe even help them stabilize momentarily.
So one of the things we haven't talked about, and we always bring this out every time we have a conversation about preventative health care in the communities of color, and it also relates to this tonight, is this family history. If you know you have a family history of some problems, you need to be attuned to that, because I think the first thing you need to recognize that Aunt Sally was acting that way because she had a problem. Okay, so how do we help Aunt Sally go talk to Brother McCall? How do we help Aunt Sally go talk to Dr. Isabell, Dr. Ford? How do we help that? And when we begin to see that same thing in maybe Uncle Johnny, what do? How do we get them into access to mental health care? Because I want people to understand out there that mental health is just a part of your normal overall health. And I want them to be able to get out there and seek the care that they need, recognize the symptoms, be aware of your family history. And there are lots of resources out there. We'll get there as we get close to the end. But Brother McCall, you have something you want to say about that? Because, I think the family history part gets left out a lot too.
So, quick story. When I was getting my master's from the University of District of Columbia, we did a genealogy class. And in that genealogy class, we had to go back and trace mama's side of the family and daddy's side of the family. And the beauty of it, I had to reach out to the matriarch and the patriarch of each family, that person who knew everybody, the one who had all the secrets buried within their bosom. And when you started talking to that person, you will find out that we intentionally hide the truth about our family ones and loved ones. There's somebody who knows everybody's sickness, and that has been that disease has been passed forward. It's easier to leave that buried than to address it, because if I address it, I'm going to open up a can of worms for everybody else to deal with. So everybody who's been walking around lying and acting like they're normal, those issues are going to come forward. So therefore, we do our best to sweep it up under the rug. Once we sweep it up under the rug, we put a heavy sofa on top of that. And on top of the sofa, we put a safe and everything else to make sure nobody can remove those items. So we need to address that, Doc. But the truth of the matter is, we need to start listening to those around us who talk. We have to listen with purpose so that we can get solutions. A lot of time, we just let people talk to say they talked, but we don't follow up with it. Go ahead, Doc.
Oh, that's a very good point. Follow up with it. There are lots of resources out there. I know in every community, I was doing some research for my church group on mental health, and every community just about out there that I'm aware of, at least in Virginia and surrounding the counties where I'm in Virginia, there is a hotline, a 24-hour hotline that you can call into, provided by each county. For the kids out there, if you're feeling overwhelmed, you can text 988 for the suicide hotline. If you're feeling overwhelmed, just text 988. If you can't remember to text 988, call 988. We call 911 when we have a medical emergency. We call 911 if you have a mental health emergency as well. But you can also call 988 directly if you speak to someone, if you're feeling like you need to hurt yourself. Those are resources out there. And every community has a 24-hour hotline in there given by the city or their county government. So there are resources out there. I mean, I could spend a whole time just talking about the resources, but that's beyond the scope of what we want to get into tonight. So now the next thing we see is we start to see older people as they age, they have problems with mental health. And how do we get them in the system? Because I mean, they may lack the resources to get the care. I mean, how do we get them engaged and involved? Because like Brother McCall said, you don't say to Aunt Bessie, I think you need to go see about your depression. Aunt Bessie might slap you down. So how do we get past that part? We got to get our people to care. And I hope there's not a shortage of people that look like us or think like us, because in any given situation, communities of color, we think differently, and so we need somebody that's going to be in tune to us. So if you, those of you out there listening, you know, there are people out there that look like us. There are people out there that think like us. So they're out there. So don't feel like you're isolated in the world, because they're out there. So go ahead. I thought somebody else said something they wanted to say. Dr. Phillips, you had something else you wanted to add on to that?
No. I was gonna let another. I thought somebody else had something to say before. I mean, what I would say is, again, unfortunately, as we get older, as I said, there are life events that can trigger depression. I know my mother is 83. Maybe about 2 months ago, she had a month where about 6 people she knew in her peer group had died. And, I'm, again, not thinking about it the same way she's thinking about it, which is not only these people dying, but also my own mortality, because I'm younger or older than these individuals. So why can't this happen to me? I think the other thing that can be problematic is that we stop interacting with our elders. So if somebody's starting to be quiet, they just old. If they're not doing or happy in the same ways, I think that because we don't engage them, we just think that it's a normal part of aging. And I will say this is my own personal experience. Too many of us don't address our hearing issues.
Right.
I get a hearing aid, and they're like, well, I don't want to wear it. And now they get isolated, intentionally also. Well, you never listen to what I say anyway, so why am I going to talk to you? But I think there's a combination of factors that make our elders vulnerable. And I think, again, that annual visit, I know you come to my office, we do the PHQ-2 and the PHQ-9 to do screening. For the elders, we have what we call an annual Medicare wellness visit, which is a more thorough physical exam for our elders that not only looks at their physical and mental issues, but their resources, their capabilities, etc. So if we have areas of identified vulnerability, we can begin to help engage them to help them out.
Dr. Mills, you see a signal? Say?
Yeah, Dr. Phillips said most of it. To add to it, when someone uses their loved one, that can put them into a depression, or if family isolate doesn't visit. But also it can be their illnesses, or is their medication. Some medications, some heart medications actually can cause depression. Underactive thyroid can increase depression. So we have to also look as the whole, the patient is what's contributing to their depression. Loss of members, family members, medications, or illness.
Right. So, but we also need to look at the aspect. We're mostly talking about how we treat them with medications, but I think a big part of it is that people need to understand that medications are just an adjunct to really talking about, like Brother McCall said, cleaning your plate. We can give you medicine to make you feel better, but you got to deal with the issues that brought you there in the first place. So you start talking about that, and address yourself, clean your plate. The two of the things that he said that I think has resonated tonight with me, that we got to look introspectively at ourselves and be able to get to our primary care doctors. Yeah, they can give us something to temporarily help us feel better, but we need to get to that person to help us work through that situation or that issue. So I think one thing I want people to take away from tonight is that, okay, talk to your primary care doctor, but realize that he or she may have a resource for you other than giving you a medication. So medication is not the answer to everything. So I wanted to hear Brother McCall's aspect on that issue. Talking about not treating everything with medication.
Sir, you're correct. Medication is not the end all be all, but with you all seeing 50 patients a day, there is a drug that will mask the needs of whoever your patients are. So therefore, you listen, you triage, you do all the things you have to do, you make a diagnosis, and you prescribe. And a lot of times the patients don't take to the medication. I don't like the way it makes you feel, but it goes back to cleaning your plate? Do you really want the help you're asking for? A lot of people come to us because we got insurance and so on and so on. Just to throw out there, a lot of if you have a job, there's an EAP. You know what I'm saying? There's a system where you can go out and get 4 or 5 visits where you can go talk to a mental health specialist. Pretty much every job, but your primary care physician, or whether you're a cardiologist or your OBGYN, they listen and they absorb all these things, but you have other specialties that you specialize in. You cannot do everything. So it's very important for the individual to want to receive the help. A lot of times we do a lot of talking, gentlemen. It's easy for me to tell you what's wrong with me. Now, after I tell you what's wrong, will I follow up? And that's the problem. We don't follow up with it. Like, I need to lose weight, but I don't go to the gym. I don't walk. I don't eat right. I will have a conversation with everybody in the world. My doctor said I'm going to get diabetics, blah, 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 but I won't do what I need to do. And it's no different with this mental health. In order for you to address your mental health, you have to seek it. And I came up with a couple of things. First of all, identify and address your issues. There's normally one thing that caused the root of your, whether it was the loss of a family member when you was young, whether you was beat, whether you went through a traumatic situation. Identify that situation and address it. Once you identify and address it, come up with a plan to seek guidance and help. After you identify, this is my root. I was beat as a kid. I have PTSD from getting beat. I was from trauma. Like, how am I going to go about that? Just talking to God and talking to the preacher ain't going to do it. Go to the EAP and sit there and talk to someone. And after you do that, sir, address your worries and stop putting attention on everybody else. We like to deflect, Jimmy. It's easy for me to talk about everybody else's problem instead of me addressing my problems. So once I identify my problems, once I come up with a process to go get help for that problem, it's time for me to clean everything off my plate and focus on me. That's the hard part. It's easy for me to point the finger at you and talk about all your things, but I don't address me, myself, and I. And once you start the process, finish it. Finish the process. If they give you 8 counseling sessions, go to all 8 counseling sessions. It may not click into the 7th counseling session, but you have to identify, create a plan, address the plan, and stop worrying about everybody else and talk about everybody else. And you have to follow through the process. And Dr. Boykin, if we could do that, mental health will become, I don't know whether we can get it under control, but it's a start to the beginning of what's next.
Wow. And that was fantastic. Unfortunately, brothers, we are about to run out of time, so we could talk another hour on this, I believe, because we need to. But I am so I want to take this opportunity to say I am so appreciative of my number, Brother McCall, coming on and helping us out tonight with Mental Health Awareness Month. It was so much information that was he imparted with us, and I'm going to reiterate his 4 steps: identify and address the problem, make a plan to seek guidance and treatment, address your own issues and worries, and follow through. Those 4 things, if you hear nothing else from us tonight, take those things home, because I think those are things, the best plan out there for us. So everybody take 1 minute, and I'm going to start with you, Brother McCall, to give you your closing thoughts to our audience out there. Go ahead, Brother McCall. Give me closing thoughts for our people out there. Take home points you want them to hear.
Oh, family, friends, as I stated, I love you, I believe in you, and I trust you. I love you because that's something we tell people that, but very seldom do we hear those words. I want you to hear it. Everybody take the time and just hug yourself. Sometimes get up in the morning when you stretch, hug yourself. Tell yourself that you love yourself. I love you. It's time for you to start loving yourself. I believe in whatever your dreams are. No matter how old you are, whether you are 75 and still want to go back to college, go to college. If you're 55 and you're dealing with medical issues, stop making excuses. Go to school, address your medicals. I believe that you have it within you to make your dreams come true or to chase your dreams. And finally, I trust you. I trust you to get the job done. Stop listening to the naysayers. Stop listening to the doubters. Love yourself. I love you. I believe you, and I trust in you. Mental health, anxiety, as I stated earlier, it's unfinished thoughts in business. Address the issues that concern you, focus on you, and by you loving you and taking care of you and trusting in you, everybody else around you, life will improve. Thank you very much. God bless.
Thank you, Brother McCall. We've run out of time, so I'm just going to go ahead and close out. Brothers, we forgive me, but I'm going to go ahead and close out. We thank you so much for coming here and partaking of our information that we have in these webinars on a monthly basis. Again, we have these webinars on the last Wednesday of every month. We stepped it up this month because of the holiday season. So I want to take this opportunity to thank Brother Piercy, who does all the work behind the scenes to make this possible. And I want to thank you, our audience, for coming in here. And last but not least, I want to thank our new district representative, Brother Amir Sharif, for allowing us to continue with this program. Everyone have a safe holiday and safe week, and have a very good night. Thank you.